Once again, we welcome you all to this second state conference, AFPI-TN 2022.
I would like to inform all that those who have registered for workshop, it is to be held at Sunshine Hotel, and the workshop will start by 9 a.m. there.
So we'll start off with the first session for today. Improvements in healthcare quality can contribute to healthcare population. However, many global and national health strategies are not sufficiently considering the issues of measuring and improving healthcare quality in low-resource settings. So the topic for the first session is Challenges of Family Medicine in Under-Resourced Settings, Applying Modern Medicine Equitably.
Chairpersons for this session are Dr. Ramya Ramanathan. She did her UG at Government AD Medical College, PG at CSI Kalyani General Hospital. She did her fellowship in the infectious disease. She is gold medalist in DNB final exit exam. Currently, she is HOD and consultant department of family medicine at Dr. Meenakshi Memorial Hospital, Chennai.
The next chairperson is Dr. Sunil Abraham, sir. He did his MBBS from Government Medical College, Calicut. He worked in a rural mission hospital in a village in central India for a year after his MBBS, which exposed him to the need of generalist specialists for India. After working another year in Christian Fellowship Hospital, Odanchatram, he sensed God's call to take up family medicine and joined the DNB family medicine program there. After completion of his course, he worked with his wife at the Tribal Mission Hospital in Anaikatti for a brief time and joined CMC Vellore in the year 2000 in the rural RUHSA department. From 2001, he has been working in the low-cost effective care unit, a 48-bedded unit of CMC for the urban poor, functioning under the Department of Family Medicine. He spent 3 years in Melbourne, where he did his FRACGP. He was a member of the Expert Committee of MCI on Family Medicine and is currently on the National Board of Examination Specialty Board on Family Medicine. His areas of interest are family medicine for the poor, whole person medicine, and teaching family medicine. He is grateful to God and believes that all he has given and there is nothing to boast about. He is married to Mary, a cochlear implant surgeon in CMC, and has 2 daughters.
Dr. John Jacob, he did his MBBS at TD Medical College, Alappuzha, Kerala, completed DNB Family Medicine in 2006, currently working as consultant in Christian Fellowship Hospital, Odanchatram, Dindigul, Tamil Nadu.
The speaker for this session is Dr. Rajkumar Ramasamy. He has graduated from Cambridge University Medical School and trained as physician in UK. He retrained as a family physician in Australia. He has been awarded with FRCP and FRACGP, and he is currently working in KC Patti as family physician.
Good morning, everyone. It is a privilege to have Dr. Rajkumar, who is my teacher, as the speaker, and I hand over the session to him.
Thank you very much, and thank you so much for the hard work that so many young people have put in to make this conference possible. It's such an important conference, isn't it? And why is it the most important conference that we are attending? Because we are doing family medicine. And family medicine is the most important specialty that India needs. India needs you. And not only that, we are practicing the most beautiful specialty in India. And so I stand before you, proud to be a family physician, and I work in a rural part of India. And what I'm going to do is to share briefly through our own story and also through the story of some of our patients why family medicine is the most important specialty. So thank you, and let's start. I didn't train to be a family physician. I went to school in UK, I studied medicine there, and I trained to be a physician there, and I enjoyed it. But I had a God-given burden that I must serve the most vulnerable people in this world. And in 1986, I came to work in a very fine hospital, the Christian Fellowship Hospital in Odanchatram. I met my lovely wife there, and we were both happy. She's an obstetrician trained in CMC Vellore, and we were busy working in this hospital, and we thought we were doing good things, which we were. But questions began to creep in my mind, because we were treating people from 10, 20, 30, 40 kilometers away from a better off background. But when we looked about 2 kilometers away from our own hospital, there were children sick with illnesses like typhoid or tuberculosis, which were rampant then, coming at such a late stage. Why was that? Why is it that people with chronic illnesses that are easily treatable, coming repeatedly with such serious complications like heart failure, they're treated, go back, and they come back again? Why is it that there were so many preventable diseases all around us, which could have been easily prevented? So we had to look for answers. And the answers we found was that we had to shift out of our comfort zone in the hospital and choose primary health care or family medicine. And that's the key to the solution of these problems. So to cut a long story short, we work in the lower Kodaikanal hills, about 50 kilometers east of Kodaikanal. There are beautiful villages surrounded by pristine forests, very pretty, but at that time when we started, appalling health parameters, with several maternal mortalities and very high infant mortality rates. We worked there as a part of a team in a health center that's located in the middle of this area, that's in Kesipati. And an important aspect of our work is the teamwork. And the team are mainly Adivasi people who have been trained by us. We also have a lot of voluntary health workers. These are men with ordinary jobs in their villages, going to the field, coming back after hard work, looking after their families, and then in the evening they double up as our voluntary health workers, treating minor illnesses and referring others to us. And also they act as our brains as well. They're not just our hands. They give us feedback and give us a pulse of what's going on in the villages. This key aspect of work, having staffing from the vulnerable community, is one important aspect of our health center. When people from the vulnerable sections come there, they feel they're at home. So that's our story, and let's get on with our patients, some of our journeys with our patients. Let's say we're in a busy morning OPD, and then in walks Panju, a 30-year-old woman who's having undifferentiated fever. Undifferentiated fevers are always red flags, aren't they? But in our health center, the health workers always see the patients first. You can see in this conversation between the two, a health worker and the patient, why that makes so much of a difference and makes the patient flow so much easier in a busy OPD. Let's hear what happened.
என்ன பஞ்சு செய்யுது?
இந்த 4 நாளா காய்ச்சலுக்கா.
4 நாளா காய்ச்சல் இருக்கா? மூக்குல சளி எது வந்துச்சாவாப்பா?
மூக்குல சளி எதுவும் இல்லக்கா.
மூக்குல சளி எது வரல. சரி வாந்தி எது எடுத்தியா?
வாந்தியாக்கா? நேத்து 2 தடவை எடுத்தக்கா.
வாந்தி எடுத்தியா? சரி மூச்சு விடும்போது நெஞ்சு எது வலிக்குதாவாப்பா?
அப்படி எது வலிக்கலக்கா.
மூச்சு விடும்போது நெஞ்சு வலி எதுவும் இல்லை. சரி ஒன்றுக்கு போகும்போது எரிச்சல் கடுப்பு அப்படி எது இருக்கா?
அப்படி எதுவும் இல்லைக்கா, நார்மலாக தான்க்கா போகுது.
சரி வெளிக்கு போகும்போது ரத்தம் சீதமா இல்லை தண்ணியா அப்படி கொலன்னு அப்படி எது போச்சாவாப்பா? அப்படி எது போகல. சரி எந்திரிச்சு நடக்கும்போது கிறுகிறுப்பு அப்படி எது இருக்காவாப்பா?
எந்திரிச்சு நிற்கும்போது கிறுகிறுப்பு இருக்குது, ஒரு சைடாக தள்ளுறது மாதிரி இருக்குக்கா.
சரி இப்போ 4 நாளாக காய்ச்சல்னு சொல்கிற, சளி இல்லாமல் காய்ச்சல் இருக்குது, எங்கேயாவது போய் ஊசி எது போட்டுட்டு வந்தியாவாப்பா?
ஆமாக்கா, இந்த 4 நாள் காய்ச்சனால பக்கத்தில் இருக்க மெடிக்கலில் ஊசி போட்டக்கா.
ஊசி போட்டுட்டு வந்தியா? சரி பார்க்கலாம் சரியா? ப்ரெஷர் பார்க்குறேன். ப்ரெஷர் வந்து 160 இருக்குது பஞ்சு. அப்புறம் அந்த ஓட்டு சேச்சுரேஷன் பார்த்தேன் 91 92 அப்படி தான் இருக்குது. பல்ஸ் ரேட் செக் பண்ணால் 126 அப்படி இருக்குது. இப்போ ரெஸ்பிரேஷன் ரேட்டு பார்த்தா 26 அப்படி இருக்குது. பார்க்குறதுல எல்லாமே டேஞ்சர் தான் இருக்குது. அப்புறம் ரத்த சோகை இருக்கான்னு சொல்லி பார்க்கலாமா?
சரிக்கா.
சரி ரத்த சோகை இல்லை. நாக்கு நீட்டு சரி, நாக்கிலே நீர்ச்சத்து கம்மியாக இருக்குது சரியா? போய் நீர் எடுத்துகிட்டு வரையாப்பா, நீரை டெஸ்ட் பண்ணலாம். சரி நீர் எடுத்துகிட்டு வந்தேன், நீரில் எதுவும் மிஸ்டேக் எதுவும் இல்லை. அப்புறம் 4 நாள் காய்ச்சல், வெளியில் போய் ஊசி போட்டு வேறு வந்திருக்கீல, அதனால் ஒரு ஹீமோகிராம் ப்ளட் டெஸ்ட் பண்ணிவிட்டு டாக்டரை பார்க்கலாமா?
சரிங்கக்கா.
சரி ஹீமோகிராம் டெஸ்ட்டும் பண்ணிட்டேன், அது டாக்டர் பார்ப்பாங்க. அந்த ப்ளட் டெஸ்ட் விவரத்தை பற்றி டாக்டர் வந்து சொல்லுவாங்க. அதுக்கு முன்னாடி இந்த வாந்திக்கு வந்து இந்த ஒண்டான்செட்ரான் மாத்திரை வந்து நாக்கடியில் வைப்பா. அப்புறம் இந்த பேராசிட்டமால் மாத்திரை காய்ச்சலுக்கு. அப்புறம் நீர்ச்சத்து வந்து உடம்புல கம்மியாக இருக்குல்ல, அதுக்கு வந்து இந்த ஓஆர்எஸ் தண்ணி வந்து 1 லிட்ரு இது குடி. பஞ்சு போனேன் நான் பார்த்தெல்லாம் முடிச்சிட்டேன். நீ ரொம்ப முடியாமல் இருக்கில்ல, 4-5 பேஷண்ட் வெளியில் வெயிட் பண்ணுறாங்க. ஆனாலும் நான் உன்னை கொண்டு போய் நான் முதல்ல டாக்டர்கிட்ட உன்னை பற்றி விவரம் சொல்லி டாக்டர்கிட்ட உன் சீட்டை கொடுக்குறேன் சரியா?
சரிங்க.
சரி
தியாகராஜன் தொண்டையை பார்க்கலாம். சொல்லுவீங்களா?
சரிங்க டாக்டர்.
சொல்லுங்க நாங்கம்மா.
டாக்டர் இந்த பஞ்சுன்னு சொல்லிட்டு ஒரு பேஷண்ட் வந்திருக்கு.
So the health worker has already done an incredible amount of assessment before the doctor sees the patient. And so it makes it much easier. She's done the vital signs. She has identified that this lady has red flags in terms of her vital signs, and she has started ORS and also ondansetron, and then advised the doctor she needs to see the patient first. So undifferentiated fevers are always red flags because they have no localizing signs, and we don't know where the infection's coming from. It may still be a viral fever, but in our area, things like malaria in those who are immigrant workers who come to the area from other states, dengue, of course, typhoid still comes in epidemics, rickettsial interactions. There are lots of ticks and leeches in our area, but the ticks are the problem. Leptospirosis due to people coming from Kerala, and pneumonia. Pneumonia, of course, is usually with localizing signs, but this common illness can sometimes present as an undifferentiated fever. And in children, urinary tract infections. Because this lady had such a high heart rate, slightly low blood pressure, it was obvious that with the 4th day of fever, she needed to go to hospital. So she needs referral. If 100 patients come like this, and I say you need to go to hospital because you need blood cultures, chest x-ray, and so on, only about 30 go. 70 don't. Because what we need to know as family physicians is that the clinical assessment is only a part of our assessment. As you go on in this conference, you'll learn about the 3-stage assessment and become familiar with it. The 3-stage assessment just doesn't deal with the clinical aspect, but asks what are the individual characteristics of this patient and what are their contextual factors. And out of 100, 70 people will say this: I know I could be seriously ill, but there are many reasons why I will not go today. And it's often likely that they will not go tomorrow also. So do we just wash our hands off these patients in family medicine? No, we don't. What we need to know as our skills, what our skills should be, is that we need to know the best and the ideal. But when they can't be followed because the clinical features are overruled by individual and contextual factors, we still need to manage them. So in our health center, the health workers' intervention with ORS and ondansetron is a key in rural areas because rehydration is crucial in febrile patients. And ORS is not just for diarrheal illness. It's a wonderful fluid for febrile illnesses as well. And ondansetron is another key development. It can restore the oral route of hydration. She had a hemogram done, and that was normal, so dengue was unlikely. So in our health center, our policy in undifferentiated fevers, where people can't go to hospital, is to start ceftriaxone and azithromycin. She was observed for the next 1 to 2 hours to ensure that her vital signs became stable. And we followed her insistence to go home. That was respected because that's what she was going to do. But the most important thing that we do before she goes home is that her name is put on an urgent recall system. What is an urgent recall system? It's just a piece of paper with a name, her clinical details, and these are discussed at our all-team meeting at the start of the day. And a phone call is made to these patients. And what a difference those phone calls make when family medicine teams make it. It makes patients feel, oh, I am so important. My life is precious, and they're taking care of me. They care for me. And when you give an advice that they need to come back, or if they're much better, take the 5-day course of antibiotics, they listen to you. I've told you this case history because as family doctors, we need to know the best, but we need to change it according to individual and contextual situations and have evidence-based protocols to follow when that happens. My next patient is a 30-year-old man, Vijay Kumar, who presents with gradual onset of poor vision in a quiet eye. That's always sad, isn't it, when it's documented and the vision is poor. So he was seen by an ophthalmologist who made an awful diagnosis, retinitis pigmentosa. And you can see in this fundus the dark choroid showing through a destroyed retina. It's a hopeless disease in many ways because it relentlessly progresses to blindness. I saw him a year on from the diagnosis. He came with multiple aches and pains, especially non-specific chest pain, which he had had for 4 months, and he wasn't sleeping well, not necessarily because of the pain. As always, the patients are seen by our health workers first. They did his vital signs, which were normal. It triggers an ESR to be done by them because he had an illness lasting more than a month. That was helpful. I saw that before I could even see the patient. And in a 3-stage assessment, they assessed him individual and contextual factors. This is an agricultural worker with 2 small children who had to work previously to earn his living. And how do you feel? What do you think is wrong? The answer was, I feel hopeless, doctor. I feel my life is useless. That statement triggers the HAD scale. HAD scale is one of many validated questionnaires that by asking a series of questions, a score is given that suggests depression or anxiety is likely, and he scored high for depression. So you say this man, young man who's going blind, is a pretty hopeless situation, isn't it? What can we do for him? Maybe he just ought to be referred to the psychiatry department. No, as family physicians, you can do a lot. The first thing that this man needs is empathy and respect, that his life is valuable. He's a male person, a breadwinner now, feels his life is useless because he can't do a job. No, you are important. You show him respect. And another key thing you do as a family physician is to say to his wife and to the patient, this is not your fault. I understand your tiredness, your inability to enjoy things, your dullness, your poor sexual life. All these things are part of depression. And the best thing is, I have good news for you. We can win over this. We can treat this. And part of depression treatment is to assess the suicidal risk. And if there is a chance of self-harm, you do what is called the suicide safety plan. This is an important skill that family physicians need to know. It's evidence-based, and it means that when you follow this as a plan, an organized plan, suicide rates are markedly reduced. It says these feelings are only temporary. They will go away. That's 1. 2, you have a list of reasons stored on your phone or on a piece of paper, the reasons why you want to live. It's maybe just a photograph of your children. 3, don't stay alone when you feel like this. Go where there are other people, maybe to the tea shop or to the sports ground. 4, you do things that you enjoy. Maybe it's just storing nice songs in your music, in your phone that you enjoy. 5, know and keep a list of people you can talk to who respect you. And 6, if none of these work, then call one of the professional helplines. That's called a suicide prevention safety plan, and that was taken through with him. And then the last is the antidepressant. People often go for that first. That's the last. And the other things, as we as family physicians are best to do, are the ones that are most important. 4 years on, this young man who is now blind he's a broken flower, but still beautiful, because his depression is treated. He comes regularly. He takes an interest in his children and his family and their education. He has a normal sexual life, and his life is something beautiful. I've shown this patient because mental illness is so common in family medicine. It's at least 1 in 10 of our patients will come with undifferentiated symptoms like tiredness, chest pains, dizziness, and we need to diagnose them. The reason is that mental illness, when it's untreated, is a tragedy. It's a real tragedy because it destroys the joy of life. And we as family physicians can treat it, and I would say better, because we don't just describe their symptoms, we understand them as people, and we deal with the people, the individual and contextual situations that are affected and need to be addressed to win over this. So take up family medicine. We are the key to it, not psychiatrists. It's too much of it that's untreated. My next patient is 34-year-old Kartaraja. He's a jolly man who goes to work in an agricultural field. He was coming back at the end of the day when in a rocky area he twisted his knee and he felt pain over the lateral side of his right knee. He's an agricultural worker with 2 small children and no land of his own. So whenever any patient comes, as I said, the health workers see them and they always have a list of red flags that they look at. Progressively getting worse, cannot weight bear, disturbing sleep, significant restriction in movements, more than a little swelling, fever or warmth, and not getting better with treatment. If these signs are present, before the doctor sees them, an ESR is done. But fortunately, Carter Raja had none of these signs. So the health worker had a little time because there was a queue of patients, and these times are not wasted. One of the things the health workers do is to screen every person opportunistically when they are waiting, at least once a year. And this is triggered by a screening sheet, which is an integral part of our medical records that the patients hold. So in this patient, his blood pressure was measured, his glucose was checked, they were all normal, so was his BMI, he was not anemic. He smoked 20 cigarettes a day for 15 years. Alcohol, okay, within safe limits. And so if there are other patients, they may have, if it's a lady, they may have a clinical breast examination every year, and they may have their lipids and so on measured. So there was still another 10 minutes before he sees the doctor. So the health worker asks 2 key questions. I'd like you to remember this. I am concerned about you, and what do you think about your smoking? I am concerned about you, and what do you think about your smoking? It's not a lecture, this is bad for you, it'll do that, it'll do this, not like that. I am concerned about you, what do you think about your smoking? Most people are in the contemplative stage. They're thinking that it's bad, but they're not ready to stop. In that situation, you do a motivational interview, which is a non-judgmental, brief intervention for those in contemplative stage of stopping smoking. If you think it takes a long time, just listen to this conversation. Sound. All right, we're not getting any sound.
அதனால் உங்கள்கிட்ட கொஞ்சம் நேரம் பேசணும். பீடி குடிக்கிறத பற்றி சொல்லியிருக்கிறீங்க. இதை பற்றி நீங்கள் என்ன நினைக்கிறீங்க பீடி குடிக்கிறத பற்றி?
தப்புன்னு தெரியுது சார், ஆனால் விட முடியலைங்க.
ஏன் தப்புன்னு தெரியுது உங்களுக்கு?
இதயத்தை பாதிக்கும், மூளையை பாதிக்கும்னு சொல்லியிருக்காங்க, கிட்னியை பாதிக்குமா, நுரையீரலை பாதிக்கும்னு சொல்லியிருக்காங்க.
இதெல்லாம் உண்மைதான். போன வாரத்தில் உங்களோட சின்ன பையன் ஒரு பையன் பீடி குடிச்சனால மாரடைப்பு வந்து கீழே அனுப்பிச்சிட்டாங்க. இப்போ வந்து ரொம்ப செலவு பண்ணி கஷ்டப்பட்டு அவங்க ஃபேமிலியும் கஷ்டப்பட்டுட்டு இருக்கிறாங்க. சரிங்களா?
சரி, அந்த நிலைமை எனக்கு வரக்கூடாது சார். எனக்கு 2 பிள்ளைங்க இருக்காங்க, மனைவி இருக்காங்க. அது எனக்கு கஷ்டமாக இருக்குது சார்.
ஒரு நாளைக்கு பீடி குடிக்க எவ்வளோ செலவு பண்ணுறீங்க?
ஒரு நாளைக்கு 30 ரூபா ஆகுது சார்.
அப்போ ஒரு வாரத்துக்கு எவ்வளோ செலவு பண்ணுறீங்க?
ஒரு வாரத்துக்கு அப்படின்னு பார்த்தா 100 ரூபா செலவு.
அப்போ ஒரு மாதத்துக்கு
300 ரூபா அப்படி பக்கம் செலவாயிருது.
மாதத்துக்கு எவ்வளோ செலவு பண்ணுறீங்க?
மாதத்துக்கு 1200 ரூபா பக்கம் வந்துடுது சார்.
அப்போ இதை வச்சு நீங்கள் என்ன பண்ணலான்னு நினைக்கிறீங்க?
இதை வச்சு பிள்ளைங்களுக்கு ஏதாவது சாப்பிட்றதுக்கு வாங்கி கொடுக்கலாம். வாரத்தில் ஏதாவது பிள்ளைங்களுக்கு கறி எடுத்து சந்தோஷமாக இருக்கலாம் சார்.
இந்த முடிவு எடுக்கிறது உங்கள் வாழ்க்கைக்கும் உங்கள் குடும்பத்துக்கும் நீங்கள் எடுக்க போகிற முடிவு ரொம்ப முக்கியமான முடிவு. சரிங்களா?
சரி.
இந்த சீட்டை வீட்டில் போய் கட்டாயம் படிங்க.
சரி.
படிச்சுட்டு உங்களுக்கு ஏதாவது ஹெல்ப் வேணும்னா எங்களை வந்து பாருங்கள், நாங்கள் ஹெல்ப் பண்ண தயாராக இருக்கிறோம். சரிங்களா?
சரி.
சரி, நான் சீட்டை வைக்கிறேன், டாக்டரை பார்க்கலாம். ஓகேங்களா?
சரி.
So remember what happened in that motivational interview. I am concerned about you. What do you think about your smoking? Remember that. I'll come back to it. But he's come to me about his knee problem. And as family physicians, we of course need to know how to do a thorough clinical examination of the knee. There's no effusion, no tenderness. There was tenderness over the lateral joint margin, but the range of movement was good. There was no crepitus. The collateral and the anterior cruciates on testing were intact, but the tests of the lateral meniscus instability were positive. So he had a lateral meniscus injury. And in most patients who have a minor lateral meniscus injury without red flags, these will improve on their own in 90% of cases within 1 month. And that's what we need to remember. We don't need to straight away do an X-ray or an MRI on these patients. So I could have just treated Kartaraja with paracetamol and NSAID, given him some knee exercises and knee supports. And that's my clinical assessment. But remember, the clinical assessment is not the only aspect we look at. What are the individual and contextual factors? This man is an agricultural worker, and when I asked him what he was afraid of, he said, I'm scared because I need to do my job, and I'm scared I will not be able to work at all, because he's a heavy manual laborer. So until he was reassured that we are going to do this, and in 90% you're going to get better, you're going to get back to work, we haven't finished our consultation. The best part of this, though, was when I saw him 3 years ago. He said 3 years later, when he brought his child and he had stopped smoking. And he said it was after that brief interview with the health worker and the information sheet he was given. This idea of brief interventions, which are non-judgmental, are crucial. If we ask the question, what do you think of your smoking? And they are in the contemplated stage, you do that motivational interview. The aim of that is to push the patient to the next stage where he's ready to act. If he's ready to act, like many people are, then make a plan. Because many people think they must stop, but they never fix a date to do it. So fix a date now with the patient in the consult. Go to the temple or the church or the mosque and make a promise to God that they're going to stop. Make a plan to spend the money that they're spending on smoking for other things. And doing this in a structured way, you can stop people smoking. 1 in 20 people have this done properly, stop smoking. And we give atorvastatin in hypertension, and only 1 person in 20 really benefits from it. This is free, and this saves lakhs by stopping smoking. My next patient is Muthulakshmi. She is a widow with no children, and she was found to have hypertension. How was she found to have hypertension? Every person over the age of 18 in our area is screened for hypertension for the last 20 years. And she was screened by the voluntary health worker who has a protocol depending on how high the blood pressure is. Muthulakshmi's name was entered in the village recall system. Each village in our area has a folder with people's names of those with chronic illnesses and those who have antenatal, under 5s, and so on. Each village has a folder. Muthulakshmi did not come as advised by the health worker, but her name was on the recall system. In our health center, 3 afternoons a week are reserved for field visits. I would advise you to look at this thing, because field visits are a crucial part of our family medicine practice. Go to the places where people live, because crucially, those who don't come to the health facilities are also seen in field visits. The hospital, those who don't come, they don't bother too much. They go. If they don't come, we ain't responsible, or they should be, but they're not responsible. In family medicine, we are responsible for those who do not come back. So the chronic disease management and the community-based preventive screening are all best done in field visits, and it enhances the effectiveness of voluntary level health workers. And if you're in the government service, when you give respect, when you go as a team to your ASHA worker, it enhances their function so much. And the rapport it builds will bring you patients, because those who wouldn't come are persuaded this team cares. They came to our village. So key part of family medicine is a robust recall system of vulnerable patients. Those on urgent recalls are discussed daily. Those on chronic disease are discussed when we go to their field visits. And the field visits allow one other key thing, home visits. I'm sure many of you have done home visits, and they're game changers, aren't they? Because when I'm in my health center, I am the king. Patients are patients, and no matter how familiar I try to make the health center, there's still a gap between them and us. But when we go to their home, they are the kings and queens, and we are just the visitor. And the interaction between them and us, what they tell us what they feel, we tell them what we feel. and the interaction is so much more enhanced. Muthulakshmi was convinced. She had to take a blood pressure tablets. And 15 years later, here's a poor widow with no children in a remote village, is taking her medications. Compliance is good. She has other preventive treatments like iron and calcium given. She has comorbidities checked, and she's on a statin. This will not happen in a hospital-based care system. It only happened because as family physicians, we take care of the vulnerable and those who do not come to the health center. That's a beautiful characteristic. Other people who are literate are also given other bits of help to help them comply with chronic disease. This is just a simple sheet. On it, it just tells in their own language, what is your blood pressure, what should it be? What is your blood glucose, what should it be? And the same for cholesterol and weight, BMI, and so on. And on the back of the sheet, it tells you simple instructions that you could do to improve your lifestyle. Those that are irrelevant are crossed out. And importantly, it gives a list of every medication they are on and why they are being given. This way of patient empowerment, which can be done by health workers over just 3 or 4 minutes, when it's done every year, enhances patient compliance. And they'll keep coming and taking their medicines because they understand what they're being treated for. My next patient is 42-year-old Velayan who has come with dizziness. Now, dizziness, when you come to a primary health center, is always a quarry, isn't it? It's so non-specific, and there are so many differentials there to deal with it. But again, the health workers see them and see how easy it makes it for the doctor who sees the patient next. They have a set of red flags for dizziness. And if these red flags are found, it triggers an ECG to be done by them before the patient sees the doctor. In this patient, assessing the dizziness may be helped if you follow the recent American Journal of Family Physicians way of classifying dizziness into persistent dizziness and intermittent dizziness. It's a good way, and I suggest you Google it and look at it because it makes it much more simple. As far as Velayan was concerned, though, he had 15 minutes when he couldn't find the words he wanted to speak, and he had transient weakness of the right side. So he is at high risk. There are red flags. And one way of assessing those with red flags, at how seriously ill they are, is to use a scoring system. There are lots of validated scoring systems and lots relevant to family medicine. And I suggest you download an app like the MD Calc app on your phone, which will help you to store the favorite scoring systems on your phone and use it. He had the ABCD2 score done. And this is a scoring system that tells you how likely a person with TIA could have a stroke. So this was done, and his stroke risk was put as 10 to 15%. So he needs a CT scan, doesn't he? That's obvious. That's my clinical assessment. He needs a CT to make sure that he doesn't have a hemorrhage so that we can start antiplatelet drugs immediately. And about 30% of our patients go and have a CT scan. What happens to the next 70% who don't go for a CT scan? Now, innaki poa maatan doctor, maybe for 3-4 days, I want to go and get some money, and I want to do that. On the one side, you don't want to treat a hemorrhage with antiplatelet drugs. On the other side, he's at 10 to 15% risk of having a catastrophe. Which do you choose? Well, as family physicians, we can chase up evidence. Look evidence up. Don't be afraid to look up evidence yourself when these situations occur. Studies show that antiplatelet drugs, even if inadvertently given to a person with a cerebral hemorrhage, don't make it worse. So I gave him antiplatelet drugs. He had his CT scan a week later. It showed a small infarct, and I was happy. You could say that's unethical, but I'll tell you the story of a similar patient who went home without any treatment when he was told to have a CT scan, didn't do it, and ended up with a right hemiplegia. And that won't be recorded as a failure. but it is a failure because we should have done something when ideal situations didn't work, and that's what we should be skilled at doing. My last patient is Tangaraj. He had an acute ST elevation MI causing heart failure, and sadly, despite all the treatment, had a reduced ejection fraction. So he was discharged from the cardiology side with complex medications that cost 600 rupees per month. But the question they didn't ask is, who is this man? He is a very nice man because he looked after his deceased brother's family and educated them. So he married late and has 3 young children of his own. He couldn't afford it. But as a family physician, when I refer someone, they are still my patients. When he came back, his name was on the follow-up register. He was visited at home on a field visit. He was in obvious heart failure, depressed, and unable to do anything. So his treatment was quickly rationalized. The most important drugs in heart failure with reduced ejection fraction are ACE inhibitors or ARBs, a beta blocker, spironolactone, and of course, atorvastatin and aspirin to reduce his comorbidities. This costs only 100 rupees a month. And he is a man who is still on treatment and able to go to work. So when you send a patient off to a specialist, they are still your patients because you can follow up on the specialist treatment and make it whole. And when finally if specialists realize how crucial family medicine is, then they will learn to work with us. So family medicine, I've told you these stories. I hope you're going to be proud of who you are. It may not command the respect and understanding that other specialties command, but it should do. And the more we do and the better we do it, it will command that respect. It may not give you the remuneration that hospital specialties give. And it does demand sacrifice. But don't worry, as a family physician, you will earn enough, more than enough. And more than the money, you get a satisfaction which other specialties cannot give. Which is more important? We live and live, earning and earning, but we are not satisfied. Here you have that satisfaction of seeing your patients better, visiting their homes, and seeing who they really are. Which other specialty enables you to share the love of God through your work to everyone, including the most vulnerable people others do not care for? Others do not care for. We are the ones who care for them. And including those who do not come to our health centers. See, without us, there is no social justice and equity. No matter how much a hospital works, if it works without primary care, they can forget it. Who else naturally integrates preventive medicine with acute care? The stories I told, the preventive medicine was naturally done, not as another program. Who treats the whole person and not just their disease? And who else knows the best modern evidence-based medicine, but is capable of adapting it intelligently to suit an individual? And equally important, we need to take this horrible load off this man's back. See, healthcare costs are the worst reason for deaths in poor people. What an indictment of medicine, that healthcare professionals are responsible for that. And we are the clue to it because we treat diseases early, we integrate preventive care, we continue chronic disease management, and we are able to tailor medicine to something that is rational, that sometimes specialists cannot do. This is a crucial aspect of family medicine. The country cannot afford the spiraling healthcare costs, neither can the individuals, and we are the solution. So be proud of who you are. Even in rural areas, quality healthcare is possible, but the key to that, as I've shown you, is teamwork. We shouldn't work as kings and queens and have other staff running around us. They are a part of a team, and if we work as a team, we can give good care, and it improves patient flow, it improves efficiency and satisfaction. There are challenges to family medicine. The increasing training options, we need to increase the training options in family medicine. You know, it's ridiculous that in India, 1% of postgraduate seats is in family medicine. When you look at every other country that has a good organized healthcare system, 50% is of postgraduate training seats of family medicine. Maybe you won't believe it. That is true. If they're going to have a good healthcare system, we need to increase it. And the only way to do that is to open up the exam so that anyone who's done 6 months of pediatrics medicine and so on in approved hospitals anywhere can sit the exam. That's the only way forward. We also need to improve the quality of family medicine because there is some awful family medicine being practiced by untrained practitioners. The only way to do that is to make compulsory CME in family medicine for family physicians. And all those entering general practice should be asked to do the family medicine exam. Then the specialists will work with us, and we need to persuade them that we enhance their care. We are not in competition. We enhance their care. Because more people come to us, the referral numbers won't necessarily decrease, but they'll be more targeted and more efficient. And when they finish, they refer back to us. And next challenge is funding. In many countries, funding of family medicine occurs in a systematic, verifiable way. In countries like Australia and Britain have developed systems where money is given for GPs who achieve targets in their community. So I'll finish off with my story about Chinna Murugan. He's a man, he's an agricultural worker. He married a woman who cannot speak or hear, and he comes up to our health center. So when I feel unhappy on some days because there are trials in working in rural areas, I see this man coming with his head held up high. Why is his head held up high? Because he knows he's coming to a place where he won't be exploited, he won't have unnecessary treatment, and more than all that, he is treated as Chinna Murugan and not as someone with another case of hypertension. Thank you very much.
Thank you, sir, for that very inspiring talk. I think it's a fantastic start for the conference in family medicine. Set the right tone. We have quick time for one question. If somebody has any question or any comments before we go on to the next session. Yeah, Dr. Tulsi.
Sir, that was a very inspiring talk. Actually, it changed my look over how I treat my patients. Sir, one quick question. Have you ever faced any medical legal issues in this kind of setting, sir? Or how do you handle that kind of situations?
Medical legal settings, what we do is we maintain proper notes. If I am treating a person who's had a TIA with aspirin without a CT scan, I write on the notes, I explain the risks, I advised him to have a CT scan, but he was unable to go. So with explanation of the risks, aspirin was started. So keeping good notes is a crucial part of overcoming the medical legal system.
Thank you, sir.
Okay, thank you very much. Over to.
Thank you, sir.